Hi, thank you so much, Tina. Good afternoon, everybody. Thank you once again for joining us. My name is Dr. Akshat Chadha, and I am a lifestyle consultant. What I basically do is I bridge the gap between medicine and lifestyle so that I can give the best of both worlds to my patient. Okay. So we have about, like Tina said, we have about 20 odd minutes today, and I want to kind of dedicate this 20 minutes to a very important topic because there are a lot of questions, there are a lot of misconceptions. Okay, so today we are going to discuss: is there a difference between hypothyroidism and Hashimoto's? Okay, so before we deep dive into the difference, so the answer is it's not a trick question. There is a slight difference. Okay, but to get into the difference, first we need to understand what is hypothyroidism and what is Hashimoto's. All right. So first, let's go back a little bit into the basics. So I don't know if you had attended the last talk also, but I had spoken about the basics. So you have the thyroid gland, which is at the base of the neck. Okay. It is the metabolic gland. It's like the most important metabolic gland in the body. And it produces two hormones. You have the T4 hormone and the T3 hormone. Okay. These T3 and T4 hormones are the ones which carry out the functions of the thyroid gland. Right. Now, what we need to understand is there is a third hormone, and we keep talking about it. It's called the TSH, the thyroid stimulating hormone. Okay. As the name suggests, thyroid stimulating hormone. As the name suggests, it is responsible for stimulating the thyroid. Stimulating the thyroid to do what? Stimulating the thyroid to release the T4 and the T3. Okay. So when you talk about the TSH, we think that is coming from the thyroid, but it's not coming from the thyroid. It's actually coming from the pituitary gland, which is in the brain. Okay. So there is a conversation between the thyroid gland and the pituitary gland. Okay. So if the T3, T4 is falling, it will go tell the pituitary gland produce more TSH. The more TSH will come, it will stimulate the thyroid gland to make more T3, T4. Okay. Suppose we say that the T3 to 4 is enough or it's going higher, it will send a negative feedback and say, okay, stop producing TSH. Okay. And that is the basic mechanism where the T3, T4, and TSH talk to each other to maintain balance in the body. Okay. For some reason, we don't know the reason, even if we don't know the reason. Suppose for some reason the thyroid is not functioning properly. Okay. It is underactive or it's lethargic or sluggish or whatever we call it. Okay. What we realize is that the TSH starts to go up. Why? Because the pituitary is trying to send more stimulation. It's trying to stimulate the thyroid gland more to produce T3, T4. Okay. So in the bargain, the TSH starts to go up. So the T3, T4 start to go down. The TSH starts to go up. Now, this condition is called hypothyroidism. Okay. I'm not getting into hyper or anything like that. This is only today the focus is hypothyroidism. Okay. So what we've understood is the TSH goes up because the pituitary is producing more of it to stimulate the gland, the thyroid gland. The thyroid gland is unable to produce the T3, T4. So eventually the T3, T4 start to go down on a blood report. This condition is called hypothyroidism. Okay. Now, when does Hashimoto's come into play? So let's say Hashimoto's is a subset of hypothyroidism. Okay. But when do we call it Hashimoto's? So we all know something called as autoimmunity, right? Autoimmune condition. So when we say that something within the body is creating problems for us, that is called autoimmunity. Auto is self, immunity is us, basically. So autoimmunity. When this happens with the thyroid gland, that something within the body, some antibody is irritating the thyroid gland, that is called Hashimoto's. Okay. So mostly, so there are a lot of types. There can be variations, of course, but today, like I said, hypothyroidism, Hashimoto's. So if you say that there is an autoimmune condition which is irritating the thyroid gland, mostly it is Hashimoto's. So a hypothyroid condition which is autoimmune will go into Hashimoto's. So technically, they are still hypothyroids. Both the patients, it is hypothyroidism. But if there is a cause, if the cause is autoimmunity, then you say it is Hashimoto's. Hope I'm kind of clear about that. Okay. Then the next question comes is that how do we differentiate or how do we diagnose the two? Okay. Is there a test for it? Okay. So we know predominantly. So the first thing is if you want to diagnose Hashimoto's, you have to diagnose thyroid. If you don't have thyroid, you can't, I mean, very unlikely that you're going to have Hashimoto. Okay. So the first condition is you have to diagnose that you have hypothyroidism or subclinical hypothyroidism. Okay. So that means you have to look at T3, T4, TSH. So you have to look at these three tests, okay? Forget the T3, T4 for some time, but suppose we say that the TSH has started going above 5, about 6, about 7, okay? Then you say that you are going into the subclinical condition, which can go into subclinical hypothyroidism, can go into proper frank hypothyroidism if it continues to rise the TSH, okay? Now, at this stage, if you look at more, you want to deep dive and say, what is the cause of this hypothyroidism, okay? Then you look at one important test, which is called the anti-TPO. I know, Luke has also spoken about this test. We've heard about it a lot. There's a lot of misconceptions about anti-TPO also, which I hope to clear. But anti-TPO is one of the most important tests to diagnose Hashimoto's. So if your anti-TPO is positive, you have technically a hypothyroid gets converted or not. I mean, doesn't get converted, but that means you have autoimmunity, which is Hashimoto's. Okay. So then you are diagnosed with Hashimoto's thyroiditis or Hashimoto's hypothyroidism, however you want to call it, predominantly. Now, anti-TPO is not the only antibody against the thyroid. There are more antibodies also, okay? But today, I want to concentrate on two things. One is the anti-TPO and something called the anti-TG, anti-thyroglobulin, okay? Now, the reason I am mentioning anti-TG is because once I say it, I want you to forget about anti-TG, or let's put it, don't give it as much of importance as you give to anti-TPO, okay? Because anti-TG sometimes does become an almost useless test, okay? It's not really specific. It might not give any information, if at all, okay? So I want you to imagine 4 scenarios on a blood report, okay? So first is that you have been diagnosed with hypothyroidism and now you're looking into the cause of finding out, okay? So you have 2 tests, anti-TPO and anti-TG. So first scenario is both anti-TPO and anti-TG are positive, okay? So that is Hashimoto's, okay? This is an oversimplified way of explaining it, but this is what you need to take away today. Second scenario is anti-TPO and anti-TG, both are negative, okay? They're both negative, so you don't have Hashimoto's. You can look at only just normal hypothyroidism, okay? Third scenario is your anti-TPO is high, that's positive, but your anti-TG is negative, okay? You still have Hashimoto's. You don't need anti-TG to be positive. If you have anti-TPO high, that's Hashimoto's, okay? Last scenario, your anti-TPO is negative. It's negative, but your anti-TG is high or positive, doesn't matter. You still don't have Hashimoto's, okay? Unless and until it is proven, maybe on like a sonography or a thyroid scan or something, which is a rare kind of a situation, but it can happen. But if the anti-TPO is negative and although the anti-TG is positive, you don't have Hashimoto's, okay? So please do not worry or even look at anti-TG with too much importance. What you need to focus to some extent, not obsess, but a little bit focus is on anti-TPO. That's it, all right? Then there is one more scenario, okay, where what happens is for whatever reason, you don't really have thyroid or, there are no issues, whatever reason it is, you went and checked the anti-TPO, okay? And your T3, T4, TSH is absolutely normal and your anti-TPO is positive. Now, in this scenario, like I said, if you don't have hypothyroidism, if you don't have thyroid, you don't have Hashimoto's, okay? So don't start worrying about it. But just as a word of caution, suppose we say that there is some family history of thyroid, okay? Just because the anti-TPO is positive, there could be a chance that you could develop some thyroid 10 years, 15 years, 5 years, 20 years, or maybe never also in the future, okay? So if you want to look at anti-TPO only, you don't have to worry about it, but take your cautions, take your precautions, take care of your lifestyle, and you might never, ever develop thyroid, okay? So what you need to understand this, anti-TPO, important. Anti-TG, not so much. T3, T4, TSH, very important. Okay. Then it's like, what are the indications? What are the indications to actually check the anti-TPO? So predominantly, there may be more also, but today I'm going to mention 2 very important indications where the anti-TPO has to be checked. Okay. Any hypothyroid lady, any lady having hypothyroidism, okay, either planning for pregnancy, okay, this is with or without medication, okay, some people are not on medication also, okay, but if you are planning for pregnancy or you're already pregnant, you have to check your anti-TPO 100%. there is no debate about this. There's no gray area about this. You must check your anti-TPO. Okay, that is one scenario. Second scenario is that suppose you see your TSH rising. When it comes back down, couple of months you make changes, and then it rises again, or it continues to rise. Let's say about 8, 9, 10, 11, 12, but you don't feel that unwell, or you don't have too many symptoms also, or you're not on medication. Maybe you're on medication also. This is the time where you have to check anti-TPO for sure. You should know, because let's say that suppose your anti-TPO comes positive, it could be an indication that the TSH will continue to rise. Okay, and if the anti-TPO is negative, it could be a good sign that you can stop worrying, and maybe you can really kind of you might never go into medication, or you can actually get off medication a little bit easier as compared to an anti-TPO positive. Okay, so these two scenarios are something that you want to focus on. Otherwise, there is a big concept like, my doctor didn't make me check anti-TPO. I've been on medication for 10 years, 20 years, but my doctor never checked my anti-TPO. Okay. Now, I don't know what happened 10 years back, 20 years back, 30 years back. Was there enough information about anti-TPO? Was the doctor aware about it? Or maybe the doctor did check it, and maybe you, didn't really pay attention to the reports. Even that's possible. Okay. So the point is, let the past be. What is important is, if you want to find out, you can find out now. But from a doctor's aspect, I'll tell you how just a little kind of my understanding also is that they might not make you test it, because one is that they're very clear. They're very clear that the TSH is rising, the TSH is going above 15, 20, you have a lot of symptoms, so you need medication. So technically, it doesn't make sense to check the anti-TPO. Personally, I will still, I still make my patients do it, but not everybody, invest in kind of doing an anti-TPO. Another reason is because it is a little expensive test also. So not everybody can afford doing the anti-TPO. Okay. So there are two ways of looking at it from a doctor perspective. Like I said, bottom line is pregnancy related, you should check it. Subclinical cases, you should check it. Okay. Then the question is, how often? How often do we check the anti-TPO? How often do we check the T3, T4, and TSH? Okay, that is actually a very important aspect that we need to discuss. What you need to understand is that anti-TPO is diagnosis. You're diagnosing the case. Okay, but you need something to even monitor. Now, when you talk about monitoring the disease, monitoring the medication, that is your T3, T4, and TSH. Okay, so my very strong suggestion and request would be, don't obsess over the anti-TPO. Okay, what you want to look at more closely is the T3, T4, and TSH. T4 and TSH being more under focus. Okay, so suppose you say, why am I saying not to obsess about anti-TPO? Is because anti-TPO has a mind of its own. So once it's high, it can kind of go up and down within the high range only. It can go up and down, and people do get happy, it's coming down, or they get upset if it's going up. But honestly, from a medically significant perspective, we don't worry about the up and down fluctuations at all. Okay. Why we don't worry about it? Because we look at the T3, T4, TSH when it comes to the medication. Okay. So I remember I had a patient, and she is one of the patients who falls in a category which we say is about less than 5% of the patients can go into something called as spontaneous remission. What that means is, technically the anti-TPO became negative. You have two reports in front of you. Couple of years back, it was positive. Couple of years back, you did it negative. There are a couple of reasons for that. Let's not get into that. But it can happen. Okay. But unfortunately for this patient, although the anti-TPO became negative, okay, the TSH didn't really come down as much as we would have liked it to come, So in that scenario, if the TSH doesn't come down, we can't reduce medication, although the anti-TPO has become negative. Okay. So what is important is that even though the anti-TPO might increase a little bit, few points here and there, no problem. Even if the TSH is coming down, that's a good sign. Okay, TSH is coming down, T4 is going up. That's actually a good sign. Okay, so that is what we want to focus on instead of obsessing over the anti-TPO. Like I said, even if it goes up and down, I needed it for a diagnosis perspective, spontaneous remission perspective, that is okay. So let's say that you really want to find out about the anti-TPO, you do it once in a year, once in 2 years, once in 5 years, once in 10 years. For me, I might never ask a patient to repeat it, or I might ask a patient to repeat it in a year or two also. It depends on a case-to-case basis, okay? But I'm a little more specific about T3, T4, TSH. And constantly I'm saying T3, T4, TSH is because it's not only the TSH. You have to look at the T3 and the T4. Okay. So when I say T3, T4, TSH, if you have any recent changes in therapy, any recent changes in lifestyle, any recent changes in medication, then I would actually suggest doing the test maybe even 6 weeks, 8 weeks also. This is the T3, T4, TSH I'm talking about. Or so that is about 2 months. You can monitor yourself in about 2, maybe 3 months also. Okay. And suppose you say, my numbers are good, my medication is stable, I'm asymptomatic, my weight is okay, I'm actually doing pretty well. Even if you check it once in 6 months, once in 4 to 6 months, that's actually pretty good. So let's say anybody on medication or subclinical, not on medication, you have to be careful. So make sure you test your thyroid at least twice a year. So that is T3, T4, TSH, not the anti-TPO. Okay. And in fact, if your anti-TPO comes negative the first time, forget about it. Please don't repeat. Okay. So be extremely careful. Then we talk about what is important is what about medications? What is the medication? So does the medication change? No. When you talk about medical, from an allopathy perspective, the medicine actually doesn't change. And that's another reason why doctors don't, jump to testing anti-TPO. Okay. Whether it should be done or not, it's different, but they don't jump to test the anti-TPOs. Why? So we know we have the levothyroxine, or thyroxine. Okay. And that remains constant. Whether you have hypothyroidism or you have Hashimotos, it remains constant. That is the T4 hormone, which is given for replacement. And that actually, if taken the right way, first thing in the morning, you're not taking anything for half an hour except plain water. So even things like lemon water, wheatgrass, moringa, Ayurvedic medication, homeopathic medications, antacids, everything needs to have a minimum gap of 30, maybe 40 minutes from taking the thyroid pill. So you get up in the morning, first thing, even before your feet touch the ground, you can actually pop the pill, and you have about half an hour to, brush and kind of have a little water and just, spend that half an hour doing something for yourself, deep breathe a little bit, whatever. But the point is, you have to give that half an hour gap. It's extremely important that you listen to me for this point and don't. So I recently had a patient, meko khane ke baad lena hai, and the patient is actually feeling better and all. Probably that person doesn't need the thyroid tablet at all. Okay. So please don't go by hearsay. Half an hour gap has to be there. It needs to be taken on an empty stomach because the absorption of the tablet happens in the small intestine. So if you have food in it, or if you have gut issues, it's not going to get absorbed. All right. Talking about gut issues, then the next question comes is that what about lifestyle changes? Do the lifestyle changes change when it comes to Hashimoto's or hypothyroidism? Not really. The answer is not really, because it's the same body. Okay. But let's put it this way. If you do have Hashimoto's, you have to be a little bit more particular. It's not, the point is that hypothyroidism will also have to be particular if they want to, get off medication. It's the same. But things like, from a autoimmune perspective, now gut health plays a major role. Okay. But again, if you are on medication, like I said, if you have gut issues, you have indigestion, you have bloating, you have constipation, you have flatulence, you have excessive burping, obviously the tablet is not going to get absorbed. You're taking 100. There's a good chance that it's only 60 is getting absorbed, 50 is getting absorbed, 40 is getting absorbed, worst case, 30 is getting absorbed. Okay. So imagine if your gut absorption improves, the gut health improves, the absorption improves, and you actually start absorbing close to the 100 mcg, then obviously the requirement will start going down. Okay. Second thing, from a lifestyle aspect, either way that we are talking about is your weight. If your weight continues to go up, there's a good chance that the medicine will continue to go up. Why? Because again, the dosage calculation is done on your weight also. So if you're going to, not make changes, and then that's another reason, right? If you have poor gut health, there's a good chance that your weight will also not come down as easily as you'd hope for it to come down. So be extremely careful when it comes to lifestyle. Two aspects: one is the gut health, and second is the weight. It is going to boil down to that. Now, just because I'm saying reduce your weight, please don't go in for fat diets, don't go in for over exercising, because the thyroid is a metabolic gland and it is going to get hit. So balance it on the 4 pillars, balance it out, do things in moderation, because that's what's going to kind of help you in the longest run. Let's put it that way. Now, just few things on lifestyle. There are few concepts and myths that are going around also. First thing is coconut oil. Okay, it's really good for the thyroid, no doubt about it. But if you're going to take 1 tablespoon, 2 teaspoons, 3 teaspoons, and you're not going to compensate or reduce your overall oil, then you're headed for trouble. Okay, there's a good chance, not everybody has it, but there's a good chance that your overall oil, ghee, butter kind of consumption goes up. Your lipids can take a hit. Now, there are two things. One is the LDL, that's the bad cholesterol, and second is the triglyceride. So you need to be a little aware of that. Just to give you a number to kind of calculate and make it easier for you, whatever you're doing, whatever oil you're taking, ghee, butter, try to keep it between maybe 4 to 5 teaspoons. That's about 5 grams. So about 4 to 5 teaspoons per person per day. Anything over this, even if it is coconut oil, it's really good for you, but you can develop other issues. Okay. So be very careful. If you're taking anything upar se, anything extra that you're taking, make sure you're compensating for the same in the food if you're already reaching the 5 or the 4 teaspoons per person per day as a number. Second is salt. Now, for whatever reason you have shifted to pink salt, rock salt, senda namak, whatever reason, if you've shifted, not a very good idea. Okay, so let's say any patient with thyroid issue needs to have about half a teaspoon of white salt. White iodized salt needs to be there in your diet, whether you like it, you don't like it, but that's enough iodine that is required. There is no point popping iodine tablets. There is no point, you have all these supplements coming in with iodine in it. There is no point taking it. In fact, it could be dangerous for you to overdo iodine. Okay. So my sincere suggestion would be to go back to either white salt, or you can mix the pink and the white salt, or I think Luke has also come up with a salt mix, which is something that you can also give a try. So be extremely careful with the type of salt that you use. But like I said, you have to have at least half a teaspoon of white salt in your diet. Okay, so be extremely careful about that. Third concept that I really want to break today is cruciferous vegetables. Anybody, doctor, expert, anybody telling you to stop cruciferous vegetables if you have thyroid, hypothyroidism, is not right at all. It's not justified at all. You can punish him if you want to, but you should not stop cruciferous vegetables at all. What you can do, of course, is don't take it in the raw form. Okay, that's okay. You don't want to take it in the raw form. That's fine. That's good. It's a good idea also. But you have to have the amount of nutrition that is there in cruciferous vegetables. You're talking about cabbage, broccoli, cauliflower, kale, radish. You have to have some amount of cruciferous vegetables for sure. Okay, you cook it and have it, but make sure a couple of times in the week you have it. Even if you have thyroid, it is eventually going to help you and not irritate the thyroid. The concept of goitrogens and all can get nullified when you cook it and have it. So anybody telling you, in fact, I'm very confident and I can say this, any food group, you don't have to kind of cut out any food group specifically. Latest I heard is someone said don't have garlic. So don't have garlic if you have thyroid. That's not true. In fact, if you do anything, you can eat everything, but you can have it in moderation, have it the right way. So like I said, cruciferous vegetables, you can cook it and have it. You do that and that's absolutely fine. All right. Last but not the least is supplements. All right. Supplements, or let's say, even if we don't talk about supplements, okay, but we know zinc, we know selenium, there's something called as L-tyrosine, and there's magnesium. So these 3-4, nutrients, minerals are extremely beneficial, So the concept is, instead of jumping to a supplement, if you can do pumpkin seeds, you can do almonds, you have sesame seeds. If you can do these, you have 1 or 2 maximum Brazil nuts are there, If you can start including these in your diet, you will actually get enough zinc, you will get selenium, you'll get L-tyrosine, and you will get magnesium. Magnesium, things like green leafy vegetables, cacao powder, Look at these instead of immediately jumping to a supplement. I would rather suggest look at it more naturally. See if you can add these to your diet, and that would be a better way of handling it from a sustainable perspective. Suppose you say that you want to supplement. There's no harm. There's absolutely no harm. But don't self-supplement. You don't know the dosage. You don't know how long to take it. You don't know what it's mixing with. Because, for example, if you're on thyroid medication, if you're on a thyroxine, if you mix the supplements within 4 hours, it can be calcium, it can be iron, it can be anything. It could be zinc, anything. If it's within 4 hours of taking the tablet, there's a good chance that it's going to interfere with your thyroid tablet. Okay. So be extremely careful about this. If you want to do it, please seek a consult. You speak to an expert. It might cost you, but it will be a good investment. because you need the right dosage. Just because it's not medication, that doesn't mean that it doesn't have an impact. It is very potent. It is doing something inside the body. So you want to make sure you know the dosage, in the right quantity and for the right amount of period of time. Okay. So just to quickly sum up, what is important is that you need to understand that they are hypothyroidism and Hashimoto's are two different conditions. Okay. And Hashimoto's is a little more difficult to kind of, get under control from a personal experience perspective. This is what I've seen, but it's not impossible. Okay. So you got to keep working on all the aspects, do it in moderation, and don't obsess about Hashimoto's as a condition. Okay. You as a patient going through the changes, you as a person going through the changes, shouldn't matter. It shouldn't matter too much to you whether it is hypothyroidism or about Hashimoto's. But yes, I do agree, knowing what condition you have is a good idea. So at least once in a lifetime, if you've been on thyroid medication, not been on thyroid medication, make sure to check the anti-TPO. Okay. Yeah. All right, Tina, do we have any questions?
Yes, Doc, we do.
Yeah. We have about 5 minutes. Yeah.
Yeah. Okay. So there is a question on how can we bring down the anti-TPO levels?
So guys, that's exactly what I'm saying. You don't, I mean, the anti-TPO has a mind of its own. Of course, you're making the changes. If the anti-TPO starts coming down, very good. No, there's no harm in that. But it doesn't matter. As long as the TSH comes down, the anti-TPO doesn't matter. And that's why I'm urging you guys, don't obsess over anti-TPO. Don't keep checking it. At least give it 1 year to do its own thing. Because anybody who has done it will realize it can come down, it can go up, it can come down, because autoimmunity is even very sensitive to stress. You are checking it at a stressful time. Could be that it's on the, So be really careful and don't obsess about anti-TPO. Please focus on the T3, T4, and TSH. Yeah, Tina.
All right. What is the right time to take our medication? Can it, someone's asking, can we delay taking the thyroid medication in the morning, although we're on empty stomach, or is it mandatory to take it right after waking up?
So you can delay it, but I don't see the point of delaying it. Unless you are doing some intermittent fasting or something, you can delay it. But I would really strongly suggest to take it first thing in the morning and finish it off, and not to miss doses for sure. So the answer is you can delay it sometimes, no problem. But try to fix a time and try to have it at the same time. And try to keep it first thing in the morning so that it doesn't interfere with your daily routine and you don't miss doses. Because what happens is, if you if you eat something, or you have lemon water or something, then you are affecting the doses. So just be careful about that.
Okay. Does Hashimoto's affect pregnancy in any way, Doc?
So like I said, you have to know if you have Hashimoto's or not. And suppose it is positive, it will not affect the pregnancy, but medication is something which you cannot stop. You cannot. So honestly, if you're pregnant, I don't know if anybody's attended, but I always say that when we are talking about pregnancy, we don't look at the mother as much as we look at the fetus, the baby, So whether it is hypothyroidism or whether it is Hashimoto's, you have to take medication. And if you're taking the right dose at the right time, I assure you, nothing will impact the pregnancy. So don't worry about getting pregnant if you have Hashimoto's, or you realize or you find out that you have Hashimoto's after you got pregnant. Take your medication at the right time, right dosage. Stay in check with your doctor and check your blood reports. That's very important. Not anti-TPO, just the T3, T4, TSH, and you're going to be fine.
Okay. I think we can take up another quick question. What is the difference between free T4 and total T4 test, and which one should be taken?
So there is a little difference. So the total is something which is bound to the protein. So there was a concept in between for about a couple of years where they said that FT4 is more, some people still follow it, is more accurate as compared to total T4. But that's the past. Unless and until, like I said, okay, you're pregnant, then you check both. You check FT4 and T4, or there is a confusion that we don't know what's happening, then you check that FT4 and T4 both. But otherwise, on a normal basis, you check T4, total T4. That's what you need to check. And suppose your doctor is still insisting on a free T4, please do the total T4 from your side. It doesn't matter. You should do T4, T3, TSH. And if you want to add the FT3, FT4, there is no harm in it.
Okay. I'm not sure if we are able to complete one last question, but let's take that up. Can you get off thyroxine completely if you have Hashimoto's?
Yes. The answer is yes, you can. You can get off it completely. Second is how long can you stay off it is the question that we need to kind of, monitor and see. But like I said, it is not as simple. It is more risky also to suddenly stop medication. But if you're doing it the right way, then it has to be a smaller dose correction on a whatever 2 month 3 monthly basis depending on how the TSH is fluctuating. But I cannot deny that there are patients who are off medication for, let's say, more than a year or even 2 years, with us also. So yes, the answer is you can, but the question is, can you do it? That's different. So till we don't understand your history, how you got it, how high is the anti-TPO, that will only get decided once we talk and we understand what's happening. But if you want to get off, you got to take the first step. Yes.
All right. Thanks so much, Doc. That's all we have time for today. But we
All right.
appreciate you taking the time, especially in answering so many questions that have come up during this session.
Yeah.
Thank you for your time, and thank you everyone for joining us this afternoon. The recording will be posted on Dr. Akshat's Instagram handle within a
Yeah.
week or so from now. Thank you, everyone.
All right. Thank you so much, everybody. Thank you, Tina.